Hello, TV 35 viewers, and thank you for tuning in. During today's segment, we are going to talk about cardiovascular care and what is offered here in Middle Georgia. We're actually very excited about a new cath lab that has been installed at Fairview Park Hospital, and we'll meet with Dr. Manuel Vega, interventional cardiologist here in town. So when we return, Dr. Manuel Vega.
Stay with us for the next 30 minutes as you meet our doctors like never before. A program that will allow you, our viewers, to make more informed decisions when it comes to your health care.
Hello, viewers, and thank you for tuning in. We are here with Dr. Manuel Vega. Dr. Vega is a cardiologist here in Dublin. Dr. Vega, how long have you been here in Dublin?
Approximately 8.5 years.
8.5 years. And how long have you been in the field of cardiology?
Oh, I started as a pioneer back in 1983 when interventions began, around 1983.
Wow, so almost 30 years of tenure in the cardiology field. Well, Dr. Vega, you are an interventional cardiologist, and one of the things I want our viewers to understand that here in the community, interventional cardiology is actually a subspecialty of cardiology and increased training that the physicians have to get. So what is an interventional cardiologist? What can you do?
Well, the normal realm is you do approximately 3 years of cardiology after you finish your internal medicine residency. And then if you want to do interventions, which is a specific field that deals with the actual treatment of putting wires and devices inside the coronary arteries, that's probably another year or year and a half more. So an interventional cardiologist is a person that's not only board certified in cardiology, is also board certified in a specialty or subspecialty of cardiology that deals with the therapeutic and the treatments of blood blockages in the blood vessels and other devices,
So what you're able to do if a patient comes in with chest pain or suffering from a heart attack, you can actually not only get an image of what's going on internally, but you can treat it as well.
Right. We can do what we call therapeutic, which is actually treatment. In the old days, when the patient went to a cardiologist that was an invasive cardiologist, what he could do was take pictures of the heart, but he could actually not do anything. Most of those times, the patient will go to surgery. And now around 1983 when I started is when we started doing interventions, so we just started doing balloonings and further procedures, and the field has changed drastically in those 30 years. I mean, I remember back in the beginning when I started in 1983, when we used to do an intervention, 6 out of 10 patients were back within 60 days for repeat procedures. Now, with the advancement of thinner stents or coated stents with medication, the likelihood of that patient coming back is less than 2%. Success rate is over 99%, and it's very safely done. It could be done in a place that doesn't have open heart surgery, since we don't send the patient just about any time to open heart surgery, so it's totally safe to be done.
So the advancements in cardiology care since you've been in the field has moved from a lot of open heart surgeries to now minimally invasive therapeutic or minimally invasive interventions. Can you explain that?
Well, when I started in the field, if you had a needed bypass surgery, the average hospital stay was approximately a week in the hospital. The recovery time for open heart surgery and bypass was approximately 2 months. Today, we can do an intervention almost, you can't say an outpatient setting, but for all practical purpose, within 24 hours, you can bring the patient in, take a picture of the heart, find a blockage, let's say a narrowing of 70 or 80%, put a stent, and the patient can go home the next day with no problem. So it's changed drastically how you can process the patient and take care of the patient in a more shorter state.
So let's go through a process, Dr. Vega, so that patients can understand. If a patient is at home watching TV, watching this show, for instance, and they're having chest pain and they're suffering from a heart attack, what would be the process for the patient to come in through the emergency department and, maybe lying here on this very table? One of the things we're very proud of and that I know this community boasts is that we have a very quick turnaround time for a patient once they arrive at the emergency room to actually having an intervention done. And explain that process. What does that look like?
Let's backtrack. The first thing is you're talking about somebody at home. Any discomfort in the chest, it doesn't have to be the classical an elephant sitting on your chest. Any discomfort in the chest that is brought on by exertion, that even at rest, that lasts 20 to 30 minutes, that may favor the left shoulder, left arm, left side of the face, the jaw, it comes and goes, lasting 20 to 30 minutes every time, that is very descriptive of heart disease or possibly a heart attack. Those patients, usually what we tell them at home is probably take an aspirin if they're not allergic to aspirin. If they're very far away and can't drive to the hospital, then they should call the ambulance service, the paramedics. But otherwise, what we do try to do is get that patient to the hospital as soon as possible.
Let's go through that one more time, the symptoms, so that everybody can catch them.
Right. The symptoms of heart pain usually is a discomfort in the chest that lasts approximately 20 to 30 minutes. The reason it lasts 20 to 30 minutes, most of the discomfort is brought on by spasm in an artery that's blocked and it's inflamed or swollen. And those spasms last approximately 20 to 30 minutes. That's how nitroglycerin works. Nitroglycerin is not a magic pill. It's a medicine that relaxes spasm in the coronary artery. So anytime you start having a discomfort, it could be indigestion, it could be increasing shortness of breath, it could be a fullness like a tight brassiere or a tight t-shirt, or a discomfort radiating down the arm or numbness on the arm that lasts 20 to 30 minutes, especially sometimes associated with some nausea or sweatiness, then you got to believe that it may be the heart, because time is of the essence if it is your heart. You need to get to the hospital as soon as possible, either by somebody bringing you here or by ambulance. Now, once you come in here through those doors in the emergency room, we have what we call a door-to-balloon time. A door-to-balloon time is how fast we can diagnose the patient if he's having a heart attack and get that artery open. The faster we get it open, the more likely we are of saving heart muscle, and the better outcome that patient's going to have and the better life expectancy that patient's going to have. So our door-to-balloon time nationwide, usually we shoot for less than 90 minutes. In this institution, we usually have it under 60 minutes most of the time, and I've had cases here where we've done a door-to-balloon time of 8 to 20 minutes in exceptional cases. So the faster we get there, the more heart muscle we save.
So a patient can come in through the front door of the emergency department and actually be laying on this table with the intervention done in 20 minutes.
I just did that last week. I had a patient with a heart attack on the bottom part of the heart, right coronary artery totally closed, and from the time he hit that emergency room, the time we got the balloon inside the artery and opened up the artery and restored blood flow was 20 minutes, which very little heart damage to that patient. The patient stayed in the hospital only 36 to 48 hours and went home with practically no heart attack. 10 years ago, that would have been probably a large heart attack that probably would have changed the expectancy of the life of that patient and probably changed his life outcome. But today, with the advancement we have and the technology we have, time is of the essence. Time is heart muscle. So we can get that open, do the catheterization urgently. The more heart muscle we save, the better that patient's going to do long term.
Very good. When we return from the break, we're going to talk with Dr. Vega about the latest technology that we now offer in Middle Georgia for cardiovascular care. Dr. Vega, when we return. And we're back with Dr. Manuel Vega, and we're actually reporting from the cath lab at Fairview Park Hospital. We're standing in front of this machine here, which is a cath lab, and Dr. Vega is going to explain to us what this machine does and how it treats patients.
Okay, this machine is our second cath lab. We have actually two full-time cath labs. So we expanded to provide this second cath lab, which is state-of-the-art. It has a very large image intensifier that uses very little radiation for the patient. This room is equipped with other tools that we did not have in the first lab, such as tools that allow us to do electrophysiological testing and device procedures for other parts, so interventional and invasive cardiology. This room, the amount of radiation the patient is exposed to is significantly decreased. The image quality and the pictures are better, so the physician can get a better idea of what is happening inside the heart. And overall, it is the latest state-of-the-art technology that's available today.
So if I'm a patient and I'm looking at this machine, it can actually be a little intimidating just from viewing it. If a patient is here and having a procedure, what would they experience? Are they going to be in a lot of pain or agony on the table, or?
No. Obviously, they may be having pain if they came in with a heart attack, but the physician will try to alleviate any symptoms. Now, if it was an elective procedure, the procedure is most likely painless. We use a little local anesthetic, and we usually give a patient some type of sedative that will calm them down and make them feel relaxed. So the procedure, for all practical purpose, I can say is painless. It's as simple as probably going to a dentist and maybe having an extraction or root canal. Probably that's more painful than actually having a catheterization. Catheterizations are pretty painless. The procedure takes approximately, for a diagnostic catheterization, about 15 minutes. The recovery time is probably within an hour. Most of the time we close the little opening we did in the leg with a little protein device, and the patient can ambulate and walk and go home within 3 hours. It's a very common procedure. It's probably the most common procedure done in the United States as outpatient. Millions of procedures are done because it is the gold standard in evaluating heart disease. And fortunately, in this hospital, we are able to do therapeutics. Therapeutic is the treatment of any blockages that we may find at that same setting.
Very good. Now explain to me, what are we seeing here on these monitors?
Well, that's pictures of what essentially happened. The picture that you may see there, I do not know if it will come out on the images, is a patient that came in with a heart attack just last week, and his right coronary artery was totally closed. As you can see a wiggly situation, and the artery is totally chopped off. And that artery was 100% closed, and that part of the heart muscle was dying. We went in with a balloon and a stent and opened that artery and restored the blood flow with excellent results. And like I said, that one was a door to balloon time of about 32 minutes, which is what we shoot for under the 90-minute mark, and we usually most of the time are in the 30 to 50-minute range on most patients. Whenever we take a picture, we have a catheter that injects dye, and as you can see, the dye comes all the way across and it's totally chopped off there. That's where the artery blockage is. What we do is we thread a little wire through there and wiggle the wire through the blockage down the artery, and then we thread over that wire a balloon that balloons that area and opens it up, and then after that we pull the balloon back up and go back with a balloon that has a stent on it. The stent opens up, it's like a mesh or a scaffold that opens and keeps those arteries open. So as you can see, this man is totally closed, and then later on I will show you a picture when the artery is totally open. We put 3 stents on this man and restore the blood flow completely in that artery.
Wow. Okay. And then after the procedure, painless, complete blood flow?
Oh yeah, the patient was totally out of pain. By the time I went in there and opened up the first ballooning and restored the blood flow, the pain subsided, the EKG came back down to normal, and the patient had no pain whatsoever. This is not a painful procedure. The pain comes from not getting blood supply. The procedure per se is not a painful procedure by any means.
Now tell me about a patient after having a stent who's non-compliant. Is there an opportunity for the artery to reocclude or to restenose?
Well, that's how technology's changed. When I started in medicine in 1983, when we used to balloon an artery, within 60 days, 6 out of 10 were back again. Then you had to reballoon it or do something else. And then we invented around 1996 the bare metal stents. Well, with bare metal stents, the reocclusion rate was dropped down to less than 1 in 4, 25%. Then we invented the drug-eluting stents, and we're now in the 3rd or 4th generation drug-eluting stent. The likelihood of that blocking down is down to less than 2% now. So when we put a stent in there, if you take your medicine, there's a good chance that you won't have to come back for a long period of time in that vessel, But you need to take the medicine. We give you medicine to prevent clotting of that artery while that artery is healing. And those medicines, sometimes like Plavix or Effient or Brilinta, you need to take those medicines for about a year. You need to follow instructions from the physician. We need to lower the cholesterol. You need to follow proper dieting. So there is a whole gamut of orders and instructions that we give the patient, and the whole objective is to try to prevent that patient from coming back and needing another procedure or having another heart attack like in this man.
So, Dr. Vega, the quality of this technology that we have here, does it rival what patients will get in Atlanta or in Savannah or the big cities?
It's identical. I mean, it is the same technology. So you're not going to get any fancier technology. In a university setting, you may get something that may be understudy, but it's not the common everyday procedure. But the same stents that we put here are put at Emory or are put at Duke University or any other major center. You don't change the quality of care. The only thing that we do not have here in this institution will be open heart surgery. And like I said, the likelihood of the need for open heart surgery is very minimal. It's less than 2% in most cases. It's just not called for. As a matter of fact, if a patient were to need surgery, let's say we try to do a procedure and we didn't like what I look, we can get a patient from here to our sister hospital in the Coliseum in Macon, probably in the same time period that it will happen while the patient's in the sister hospital. So there is no delay. We get an ambulance and transport that patient, get him directly to the operating room if that were to be needed, which is, like I said, very rarely needed. This is the case of the artery that was totally closed, and as you can see, we passed a wire through it. And then we came in and we ballooned the area and ended up putting a total of 3 long stents and opened up the artery. Can you go to the
next? You see the blood flow.
You can see the blood flow now. At the beginning, you see the blood flow stop completely right there.
Right.
And now you can see the blood flow coming after we ballooned it. Next picture, please. And then you can see a balloon down there with a stent. I'm putting a stent down there. Next. And then another one over here. Next. You can see the blood flow is much better down there. Next. Long stent.
Wow.
Really long stent. Next. The blood flow is much better down there. Then we came back and tacked that up all up. This is another stent here. Next. As you can see now, you can get a good blood flow down that artery. Next. And that's the last stent, the third stent that we put in. It's crushing the plaque. It's a scaffold and opening, restoring the blood flow. Next. Next. And this is the artery after all the 3 stents. Beautiful, brand new artery, blood flow perfect to the artery. And we have stopped the heart attack in that patient.
Fantastic.
Okay.
Very good. So in our final segment with Dr. Vega, we're going to come back and talk more prevention for patients to make sure that they take good care of themselves. Dr. Vega, when we return. And we're back with Dr. Manuel Vega, and during this last segment, I want to really impart to the community what we need to do to take care of ourselves, to maintain healthy lifestyles. And Dr. Vega is going to talk to us about preventive ways to not have heart disease.
Well, in actuality, we always talk and think certain things may be producing or aggravating heart disease, but there really are 5 risk factors that we try to modify. The first risk factor in developing hardening of the arteries is getting older. The older you will get, the arteries will get clogged up. So aging or getting older is part of natural hardening of the arteries. So I've had patients that say, I'm a vegetarian, I'm 80 years old, why did I have the heart attack? Because you were 80 years of age. But there are 4 risk factors that we can all, as persons, can try to modify to lower the odds of this hardening of the artery process. The first one is the sugar. If you are diabetic, you need to monitor that sugar by following proper diet. The outcome that's more important is what we call the hemoglobin 1AC. That should be 6.5 or less. If you have 6.5 or less, you'll have less heart attacks, less dialysis, less bypass surgery, and less vascular problems.
Now, how do we control for hemoglobin?
We monitor it with blood tests. Hemoglobin 1AC is a blood test.
Okay.
We control it with dieting and medications, such as insulin in some patients, or just dieting in other patients, and weight reduction. But the important thing is the number. The number is 6.5 or less hemoglobin 1AC. Okay. Another risk factor that's very important is high blood pressure. So high blood pressure is called a silent killer. Originally, the blood pressure monitoring that we shot for was 140 over 90 or less. Now we've gotten a little bit more specific about that, and we really shoot for 135 over 85 or less. If we can keep those numbers, we increase the likelihood of that patient developing premature hardening of the artery, which is the whole outcome. The third one, which obviously, is the tobacco. Cigarettes make your blood vessels age faster. So if you smoke, you may be 50 years of age, but your blood vessel may be that of a 75-year-old, because the cigarettes make your blood vessels just get harder, and the hardening of the arteries happen faster. And the last one, which everybody knows about, but it's very important that people do not pay attention, is the cholesterol. We have cholesterol, and we have certain cholesterol numbers that we like to shoot for. We like to see the total cholesterol under 200. We like to see the good cholesterol. I call the HDL, the good cholesterol, the catfish, is the one that cleans up the arteries. We want to see an HDL greater than 45. And the last thing is the bad cholesterol, the LDL, or lousy or bad cholesterol. We like to see that under 100. If a patient has heart disease, we probably like to see that under 70. If you hit those parameters, most of those patients will do very well. Other things from preventive medicine you can do is a baby aspirin a day, if you have no allergy or no contraindication, lowers the odds of you having a stroke or a heart attack by 40 to 70%. There's nothing cheaper you can buy than a baby aspirin that can do that's such a benefit to a person. Other things that we do is obviously lower the cholesterol and modify the risk factor. But a baby aspirin, if you're over the age of 50, you have no contraindication, and hitting the right cholesterol, right blood pressure, not smoking, maybe an exercise program, all that can all prevent the natural occurring process of hardening of the arteries. Most premature hardening of the arteries occurs because of lifestyle, bad habits in the lifestyle. If you do lifestyle changes, you will do well.
Thank you for sharing with our viewers how we can prevent cardiovascular disease, and then also how it's treated here in Dublin. Any lasting words for the viewers?
No, we're always open. We have the latest technology here in Fairview Park Hospital. And don't hesitate. Come to the emergency room if you think that you're having a chest pain or possibly a heart attack, because time is of the essence.
Thank you, Dr. Vega.
Okay, you're welcome.